Hi, I'm Dr. Bart Ripberger. I've been a private practice physician in Phoenix, Arizona for over 18 years. I've owned and operated DocCMR and StarWriter medical data for the last 16 years, and I've converted to managing StarWriter docs full-time for the last 7 years. I'm a lower extremity specialist. Most of my focus was on diabetic wound care and limb salvage. The relevance to coronavirus infection: most diabetic wounds are infected. Also, there are numerous infected organisms affecting the lower extremity: bacteria, virus, fungi, and others. So I have extensive background in treating and dealing with numerous types of infected organisms. Additionally, I'm a physical fitness enthusiast, and I believe in staying in shape. I've consulted in both health and wellness as well as physical fitness. I've combined both of these experience and knowledge sets, my history as a physician, as well as my past experience in physical fitness and health and wellness, to derive the following recommendations on both the approach to coronavirus and, more critically, the prevention of more individuals succumbing to the disease. Before we delve into our conversation, a quick word of caution. The theories discussed in the presentation are precisely that: theoretical at this time. These theories and proposed treatments for coronavirus are based on sound medical science, but more testing is needed to confirm that these proposed treatments are indeed a better way to approach and treat coronavirus. To date, we've attempted social distancing, masks, and even shut down the U.S. economy, costing millions of people their jobs and bankrupting businesses. Yet the net result: coronavirus cases, hospitalizations, and deaths continue to rise. And a couple quick graphs here. The one on the left shows my home state of Arizona for deaths, and it shows obviously just a perpetual upward trend. Take note that at the very right side of the graph, we do see a little bit of a dip appearing now, so that's a good thing, but overall the graph continues to rise. Same thing with the hospitalizations graph on the right-hand side. Hospitalizations for the U.S., again, just a continual rise. So it's time to consider different approaches and recommendations to attempt to get better results for the American public. The goal of this video is to raise funding to execute testing, preferably from government, perhaps Governor Ducey in my state of Arizona or President Trump, to confirm these proposed approaches will benefit society and improve both the physical and economic health of America. So let's take a minute for increased appreciation of disease and focus on perspective. In my experience treating diabetic wounds, we would see that many are infected, yet the patient does not show systemic signs of illness. So they weren't, quote, sick, even though the wound was infected. The same holds true for coronavirus. We can draw a direct correlation. As most of us are probably aware, patients can test positive, yet they don't show any real signs of illness, and they're not, quote, sick. Another example of this is with TB or tuberculosis. Many healthcare workers will test positive for TB on the skin test, or we call the mantle tuberculin skin test, and yet they do not have active TB. The principle holds for multiple other disease processes where an individual can test positive for a disease and yet not show signs and symptoms. So the person really isn't, quote, sick. This brings us to the take-home message. The important concept here is what we call the MID, the minimal infective dose. What is MID, or the minimal infective dose? We can think of this as a baseline measure for the number of pathogens our body or immune system can handle until the person gets sick. So in our baseline here, if the numbers of pathogens, bacteria, virus, fungi, parasites, etc., remain below that MID, or the minimal infective dose, our immune system can keep up and the person does not get sick. However, if the number of pathogens rise above the MID, then our immune system can't keep up and now the person becomes sick. We take advantage of this concept in our vaccinations. A vaccination is actually a small quantity of the disease or pathogen, and with this small quantity, our immune system develops antibodies and learns how to fight the disease process. We develop immunity. We're all probably familiar with common vaccinations we're given, i.e. our annual flu shots, childhood immunizations like MMR, DPT, etc. They're giving a very small quantity or an amount below the MID that our immune system can keep up on. Our immune system learns how to fight those particular pathogens, and then we develop immunity to that particular pathogen. So the key is we want to maintain our patients below the MID, but not allow the number of pathogens for the patient to rise above the MID. How can we use this concept to stack the odds in our favor? Our critical goal should be, again, focusing on keeping patients below the MID. Preventative action should be playing a much larger role. Waiting until patients cross the threshold MID is problematic because, as we're seeing, once people become sick and cross that MID threshold, the outcome is hospitalization and possibly death. So first, let's understand what a virus is and how it differs from a bacteria and why viruses are more difficult to combat. A bacteria is a single-cell living organism that can reproduce on their own or independently inside or outside of a host. We can identify these by growing them outside the human body in any kind of a favorable environment, typically on what we might call an agar plate. And here we've got a quick slide of a bacterium. If we look on the inside, we see kind of the little purple, what we call organelles on the inside. These are items that assist the bacterium in its independent cellular reproduction. And then on the right side here, we have what we call an agar plate. And this agar plate is used to grow the bacteria outside of the body, so we can actually capture those and identify them microscopically. And the important thing to notice here are these small white dots. These would be individual colonies of bacteria. We can see we can grow these independently in an optimum environment, and so we can actually examine these microscopically. In contrast, a virus is a packet of genetic material surrounded by a protein coat, or what we call a capsid. They're not capable of independent reproduction. They must invade a host cell, in our case our own human cells, and the viruses then hijack the host cell. The host genetic material is literally hijacked, and the virus injects their own genetic material that instructs the host, the human cell, to manufacture more of the virus instead of manufacturing more host cells. We'll see this in the diagram below. And this diagram shows just a quick pathway of a virus life cycle. You can see first steps here, what we call attachment, where the virus attaches to the outside of our human cells. Then we have penetration, where the virus actually invades the host cell. Then it will, what we call, uncoat or release its genetic material inside. The genetic material then merges with our genetic material and instructs our cell to make more viruses. So we're going to have assembly of more viruses, and it's going to continue on until it basically fills the cell, and the cell then lyses or breaks open and releases out into the body. Quick summary, we've got one cell using our cells as a host to manufacture many more. This is the difference between a virus and a bacterium. Bacterium can reproduce on their own. Viruses need our cells to manufacture more of them. Antibiotics will kill bacteria by blocking one or more of the bacterial's biochemical pathways, or by blocking the bacteria's ability to form a part of its structure that's required to reproduce itself. Antibiotics do not kill a virus. The challenge is, since the virus invades our human cells, it's almost hiding inside our cells, and it's using our cells to build more viral particles. Since a virus is literally inside our cells, a chemical agent that kills a virus has to be very selective to only affect the virus or part of the virus, typically its enzymes, yet not affect our human cells, which are acting as the host. This is what makes viruses more challenging to combat than bacteria. So since we cannot simply take a pill to kill a virus, and since we do not have a vaccine currently, what actions or treatments can we take to prevent people from surpassing the MID and getting sick from coronavirus? At a high level, let's first look at a technique that could be used to keep patients below the MID and prevent them from becoming sick. This technique is straightforward. It's called dilution. Dilution means we're simply reducing the number of viruses and viral infected cells to keep a person below the MID. We will keep dilution as the important element here, and we'll come back to this in just a moment. First, let's focus on the path of infection and spread of coronavirus. We all know that coronavirus starts out as a respiratory tract disease, ultimately an advanced stage that can affect multiple other systems, but it starts as a respiratory tract disease. Let's look at the anatomy of the respiratory tract, diagram of the respiratory tract. And the first area that will be contacted by coronavirus is the nose and oropharynx, which is the nose, mouth, throat area. The virus then spreads down the trachea through our bronchi and out into our lungs, even into our alveoli, or the air sacs. Now let's consider the microscopic view of the oropharynx, or any tissue. As we're probably all aware, we have layers of cells that come together to form tissues and structures. And we can see we've got the different layers so this would be your mouth, and the cells deeper into the deeper tissue layers. Critical question, which cells would be infected first? So remember, viral particles, we're breathing those in, they're going to be here in our mouth. Which of these cell layers are going to be affected first? The superficial cells that are easy to reach and readily contacted by virus, or the deeper cell layers? Answer, the superficial cell layers are going to be easier and literally take less effort to reach. It would take a lot more effort for a viral particle to move its way down into these deeper tissues or deeper cell layers than for it to invade these superficial cells here. The virus is going to be on the surface of a tissue or affect those more superficial cells. In our case of the oropharynx, we can use this to our advantage. If we can remove free-floating viruses and superficial layer, we will reduce or dilute the numbers of free viruses and the host cells that are most likely to be infected. This would be a very positive thing for our patients. So let's look at techniques for dilution. As a surgeon, once we complete our surgical repair or procedure, the last thing we do before we close or suture the patient's surgery site closed is flush. Flushing is exactly what it sounds like. We're literally pouring sterile water or saline over the surgical site to move and dilute pathogens. Flushing accomplishes several things. It removes any tissue debris from the surgical site that we might have, and it dilutes the numbers of pathogens that may be present in the site. A real-world example of this dilution and being able to move things with water comes when we hose down our driveway. We've probably all done this. We all know that when you spray water on your driveway, the water moves the superficial debris like grass, dirt, leaves, etc. Important point, we also know the more pressure you apply with a spray nozzle or even with your thumb, the faster the debris moves down your driveway. However, even if you simply turn your hose on at the top of your driveway and let the slow flow of water run down your driveway, it will remove debris. More pressure moves debris faster, but even a slow flow of water flowing down your driveway will clean it. So fluids move superficial debris. We use this principle of increasing the pressure of our flush in surgery also. We have devices we use that apply increased pressure to the flush process, which we call power lavage. So the concept, moving any water over an area is good for flush, but adding pressure makes the flush even more effective. What are some of the concepts we need to consider in preventative treatment of coronavirus? Number one, for the nasopharynx or nose, simple nasal flush. There's numerous products available that are OTC, over the counter for this, and they're very effective. For our oropharynx or our mouth and throat, the simplest thing we all need to do is drink more fluids. Just like we saw the slow flow of water will clean your driveway after a period of time, similarly, drinking fluids all day will help flush some of the superficial cells and viruses off of the back of your throat or oropharynx area. Number two, we need to consider methods to create more pressure to more effectively flush the oropharynx. The simplest way to achieve this is gargle. Two excellent products to consider for this. Number one, the recently approved povidone iodine gargle from Mundipharma. And number two, Coldzyme mouth spray manufactured by Enzymatica AB. A recent study shows it may be effective in deactivating the SARS-CoV-2. If you cannot get any of these excellent products, even gargling with Listerine or Scope is better than nothing. Why? Because we're creating more forced pressure against that oropharynx and giving us a more effective flush. The third one's probably the most interesting, creating high pressure flush of the oral pharynx. Now this would have to be performed by our dentists, but we've all been to the dentist. We know they can give you that high pressure flush after the dentist does some work. So they have the devices currently in their office to do this. With the Mundipharma povidone iodine solution, they could literally be high pressure flushing the oral pharynx and simultaneously suctioning out the povidone iodine solution at the same time, but done under appropriate supervision at our dentists, would be a very effective treatment. More testing needs to be performed to determine the duration and frequency to maximize the effect of these treatments. The next area we'll focus on is the most seriously affected body system by the coronavirus, our lungs. There are three primary concerns here. Number one, buildup of fluid in our lungs, increased number of virus in our lungs, and fibrosis of our lungs, where our alveoli, or the air sacs, become fibrotic or rigid. They lose the normal elasticity that's necessary to inflate and deflate our lungs, or to pull air in and out of our lungs. We lose that capability due to fibrosis, or a more rigid state of the lungs. So how can we prevent these three negative effects? Simply move or exercise our lungs early. Exercising our lungs and deep breathing is the key, but we have to do it early in a preventative fashion. For example, after a patient just tests positive, but before they show any other symptoms. Some of the most common treatments for this in healthcare are, number one, PEP, positive expiratory pressure, probably the most effective since this device forces expiration. And number two, a possibility could be incentive spirometry. Well, incentive spirometry, the opposite, it forces inspiration. But if we take a deep breath in, we consequently have to take a deep breath out, which is still exercising our lungs. So this device, the incentive spirometry unit, might be a good alternative for exercising our lungs and that deep breathing as well. Both positive expiratory pressure, PEP, which focuses on exhaling, and incentive spirometry, which focuses on the inhaling, force the patient to breathe deeply. Deep breathing with assistance of either of these devices assists with three things. Number one, prevents fluid buildup in the lungs. It decreases the number of viruses in the lungs and clears the lungs of pathogens. And number three, it prevents that pulmonary fibrosis that we're concerned with. Now, a little more detailed look at each one of these. PEP incentive spirometry can help prevent fluid buildup in our lungs with rapid forceful movement of the air in and out of our lungs and alveoli. PEP and incentive spirometry are literally forcing more virus particles out of our lungs. It's well known that the coronavirus is being transmitted on respiratory droplets. So instead of sitting around and letting the virus literally incubate and multiply in our lungs at will, we want to do just the opposite. We want forced deep breathing to blow more viral particles out of our lungs. We're accentuating the same effects as a sneeze or a cough. Forcing viral particles and infected cells out of our lungs with deep breathing is yet another mechanism to keep patients below the MID. What else could younger people do to achieve the same result as PEP or incentive spirometry? Exercise. This is a key. Exercise. Running, hitting the gym, rigorous weightlifting, biking, swimming, hiking, CrossFit, etc., all done in a rigorous fashion to force deep breathing and therefore force more viral particles out of our lungs. The third benefit of deep breathing is prevention of pulmonary fibrosis. Pulmonary fibrosis is a formation of fibrotic rigid scar-type tissue on the inside of our lungs, which causes rigidity and prevents the lungs from expanding and contracting and moving air in and out of our lungs efficiently. But let's look at a couple principles. When the body is held still or without movement, this promotes rigid healing, i.e. a broken bone. A very simple example we can see of that. The immobilization and rigidity allows bone cells to heal across a fracture site. We may use a cast or even internal fixation to immobilize a bone fracture, and we're trying to hold things still so we can get rigid healing. Pulmonary fibrosis, or that rigidity in our lungs, is problematic. We want to do just the opposite. So instead of immobility, we want lots of movement. Forced deep breathing from exercise in people who can, or from PEP or incentive spirometry for people who cannot tolerate exercise. Other folks are probably very able to exercise, Maybe they've never worked out before. We're not going to throw those people into the gym and try to get them involved in rigorous exercise. That's probably too much for those folks. But what we can do is get those people using PEP or incentive spirometry. Now, the links below are YouTube videos that demonstrate PEP use, incentive spirometry use, and deep breathing during rigorous weight training and running to give you a better idea of what we're talking about. Can we remove viral particles and viral infected cells out of our lungs? Can we reduce the number of viral particles and infected cells below the MID? We're all aware that coronavirus is transmitted on respiratory droplets. An excellent study was done to capture respiratory droplets with a sneeze, singing, talking, and coughing. The respiratory droplets were captured on what we call an agar plate. These droplets had bacteria that grew out on the agar plate, not coronavirus. So this is not a perfect test, but it's a very good sampling. The key is the test shows the respiratory droplets that we all agree are the transmission method of coronavirus. We see in the image below, talking barely rid the lungs of anything. And here we've got our agar plates here. We see the different testing results from a sneeze, singing, talking, or coughing. And what these dots represent are the number of respiratory droplets that were captured on the agar plate. Respiratory droplets, we also know, are the transmission method of coronavirus. So we see talking barely rid the lungs of anything, whereas coughing, which approximates deep breathing we get from exercise, PEP or IS, rids the lungs of considerably more material. We can see here the difference between these. Talking barely rids anything, as opposed to two coughs. Look at the increase in the number of respiratory droplets that were expelled. Preventative action with forced deep breathing, PEP, IS, exercise, and observing appropriate social distancing appear to be keys to keeping patients healthy. So the key question that we're really looking at, do we want the increased viral particles that we see here outside of the body, or do we want those inside the body? As we see, talking is doing very little to expel any of those respiratory particles. So we conversely know that all of this is literally staying in the patient's lungs. With no deep breathing, with minimal activity, we can see all of this is literally staying in the patient's lungs. With coughing or exercise or deep breathing, those respiratory droplets are now outside of the lungs. So do we want this outside of our patient's lungs, or do we want it inside the patient's lungs by sitting around and not doing deep breathing? We want more outside of our lungs. We don't want this inside our lungs where it only incubates, grows, and makes our patients more sick. Exercise, folks, is the key. In conclusion, we need to explore alternative treatments. What we're doing currently is not getting the American public the results we're looking for. So additional testing needs to be done. We need to test the distance respiratory droplets travel. Is 6 feet really adequate for social distancing? How many viral particles can we forcibly blow out with deep breathing exercises? A number of questions on masks. Number one, how much of respiratory droplets do they actually catch? Do they lock into that mask? And if social distancing works, why do we still need masks? If we're inside 6 feet, we certainly need the mask, but why do we need a mask if we're outside of 6 feet? Isn't this belt and suspenders? If a mask really captures everything, why do both parties need masks? Wouldn't one mask between two people provide adequate protection? If we're outside of 6 feet, remove the mask and clear the lungs of as much pathogen as possible. Leads us to our next issue. Masks typically make us rebreathe recycled air, which has viral particles in it. Aren't we continually reinfecting ourselves instead of actually blowing the viral particles out of our lungs and diluting the concentration? So is a mask actually causing us to rebreathe that same air that's infected? We need studies on this to determine what's really happening. What's the variance of droplet capture between masks constructed of different materials? We know all masks aren't created equal. Propose alterations in our approach to COVID. Number one, a positive test does not mean certain death. We need more accurate reporting of critical testing and scientific data. We hear far too much in the media about people being positive for tests. It almost appears that that's certain death. We need to inform the American public that it's not. We need much more emphasis on preventative medicine, taking measures to keep people below the MID when they're first diagnosed with COVID or when they first become positive before they start showing symptoms, instead of waiting until people get sick or above the MID to actually take any action. We need to emphasize deep breathing and lung exercises by, number one, reopening gyms and emphasizing physical activity for people who can, and emphasizing PEP and incentive spirometry for anyone who cannot work out. We need to drink more fluids perpetually, gargle frequently, and investigate naso and oropharynx flush. All of this needs to occur to emphasize preventative measures, physical health, and a return to normal socioeconomic balance for the good of the American public. And finally, caution, more testing needs to be performed on these proposed alterations in our approach to and preventative treatments for coronavirus before people accept these as best practices. The goal of this video is to obtain funding and support to perform the necessary testing to prove the validity of these proposals. Contact, again, I'm Dr. Bart Rittberger. Here's my best email, bart@drbartsolutions.com. Thank you for your time and your support. Look forward to hearing from you soon.